everyone. My topic is treatment-resistant schizophrenia. I'm a moderator, Sanjeevi ma'am. About one-third of all patients with schizophrenia are resistant to drug treatment, and patients with treatment-resistant schizophrenia are found highly symptomatic, requires extensive periods of hospitalization, and compromise a high share of total cost towards treating schizophrenia. In current scenario, treatment resistance has generally been conceptualized in terms of ignoring positive psychotic symptoms, and other features of schizophrenia can contribute to poor psychosocial functioning like negative symptoms, affective symptoms, cognitive deficit, disorganized behavior, and drug side effects. Now, what is treatment-resistant schizophrenia? According to Keynes' criteria, it is under three-dimensional. One is historical, second one is cross-sectional, third one is prospective. Now, in historical, at least 3 periods of treatment with antipsychotic of at least 2 different chemical classes with dose equivalent to 1000 milligram per day of chlorpromazine for a period of six weeks without significant relief and no period of good function within the preceding 5 years. And in cross-sectional, a score of at least 45 in the DPRS with scores of at least 4 in 2 of the following metrics. That is conceptual disorganization, suspiciousness, hallucinatory behavior, and unusual thought control. And CGI score greater than equal to 4, that is moderately ill. And in perspective, no improvement after 6 weeks of treatment with haloperidol up to 60 milligram per day or higher dose. Now there is modified criteria of Conley and Kelly. This is a drug refractory condition, at least 2 prior drug trials of 4 to 6 weeks duration at 400 to 600 milligram of chlorpromazine with no clinical improvement, persistent of illness, no stable period of good socio-occupational functioning in last 5 years, and persistent psychotic symptoms. Here the total DPRS score will be greater than equal to 45 on 18 item scales and greater than equal to 4 on at least 2 of 4 positive symptoms. Now, definition of treatment-resistant schizophrenia. One definition is early onset treatment-resistant schizophrenia. Here, within 1 year of treatment onset. Then, medium-term onset treatment-resistant schizophrenia. It is 1 to 5 years after treatment onset. And in late onset treatment-resistant schizophrenia, greater than 5 years after treatment onset. Then there is also ultra treatment resistant. Here there is treatment resistant schizophrenia plus failure to respond to clozapine. We'll discuss all this in detail. According to American Psychiatric Association, definition is greater than equal to 2 failures and greater than equal to 1 second generation antipsychotic with treatment duration greater than equal to 6 weeks, and failure criteria will be little or no symptomatic response to trial of adequate duration and dose. According to NICE 2014 guidelines, greater than equal to 2 sequential failures, greater than equal to 1 non-clozapine second generation antipsychotic, treatment duration will be 4 to 6 weeks, and illness has not responded adequately despite established adherence to antipsychotic medication. According to British Association for Psychopharmacology, minimum number of failed antipsychotic trials will be 2, and specific antipsychotic will be one of the trials should be of antipsychotic with an established favorable efficacy profile in comparison with other antipsychotic. Dose should be adequate, and severity of the illness should be schizophrenic illness and shown a poor response or intolerable to the neurological side effects of the previous treatment. According to Maudsley, minimum number of failed antipsychotic trials is 2, and we will consider use of either first or second generation antipsychotic. And 2 to 3 weeks for trial of first antipsychotic in first episode of psychosis, and 6 weeks trial for subsequent antipsychotic before closing. Important points in assessment of patients of treatment-resistant schizophrenia. We will confirm the diagnosis and assess the medication, the type, dose, duration, the adherence to the treatment, side effects, comorbidity, organicity, and persistence of significant symptoms despite adequate treatment. Now, in this, when we are seeing a patient of treatment-resistant schizophrenia, we will see patient is he given an adequate antipsychotic trials, adequate dose for at least 6 weeks duration. If they show adequate response, we will continue the same dose of antipsychotic medication and we'll continue to monitor the side effects. If there is non-response to treatment, we will reevaluate the diagnosis and the medication compliance. If it is a true non-response, we will change the antipsychotic medication. Failure of 2 adequate trials of antipsychotic, we will one of which is second generation antipsychotic, then we will consider clozapine. If the patient shows adequate response, we will continue with the same antipsychotic and we'll monitor the side effects. If inadequate response to clozapine, then we will consider combining clozapine with ECT or another antipsychotic medication. And there is pseudo non-response due to poor compliance, then we will evaluate the cause, we'll address the same and ensure compliance. And in case of poor compliance due to intolerable side effect, we'll consider change of antipsychotic. Now, one is treatment-resistant schizophrenia, and one is pseudo-resistance. So, in treatment-resistant schizophrenia, the cause is pharmacodynamic factors. We will see the adequate dose and duration of antipsychotic treatment associated with early age of onset and long duration of illness, and the biological differences from treatment-resistant schizophrenia. In pseudo-resistance, we will see the causes either clinical or pharmacokinetic factors. It could be either due to incorrect diagnosis, inadequate dose or duration of antipsychotic treatment, insufficient plasma level of antipsychotic medication, poor treatment compliance or adherence, adverse events or comorbid medical condition making response, and substance use. Now, the management. According to NICE guidelines, inadequate response to pharmacological or psychological treatment, then we will review the diagnosis. We will establish the adherence. If family intervention is there, then we'll suggest CBT. We'll consider other causes of non-response. And if there is any comorbid substance misuse and concurrent use of another prescribed medication or physical use. Now, treatment can be pharmacological or non-pharmacological. In pharmacological management, we will optimize antipsychotic trials, that is 300 to 600 mg of chlorpromazine, equivalent for 6 to 8 weeks, trial of depot if not done earlier, and treat any extrapyramidal symptoms. Then switch to novel antipsychotic with prostatic for 2 to 4 weeks. We can add risperidone 2 to 6 mg per day, olanzapine 15 to 25 mg per day, or quetiapine 300 to 450 mg per day for 6 to 8 weeks. Then switch to clozapine. Plasma level of 300 mg per liter should be aimed to ensure inadequate trials. Target dose for female non-smoker is 250 mg per day. For male non-smoker is 350 mg per day. And for female smoker is 450 mg per day. And then we can offer clozapine to people who qualify the criteria for treatment resistant. And inadequate response to clozapine, we measure the therapeutic drug level before adding another second antipsychotic to augment treatment with clozapine. If no response, discontinue clozapine, and third-line strategies can be ECT. Then role of conventional antipsychotic in treatment-resistant schizophrenia. Less than 5% response on changeover from one first-generation antipsychotic. Then role of second-generation antipsychotic in treatment-resistant schizophrenia. First is clozapine. According to multi-center trial, clozapine compared to chlorpromazine, 30% compared to 4% chlorpromazine after 6 weeks trials. Only a drug with proven efficacy in rigorously defined treatment-resistant schizophrenia is superior to conventional antipsychotics. And role of other antipsychotic is olanzapine, risperidone, quetiapine, if not as, but these are not as effective as clozapine. There is another term, clozapine-resistant schizophrenia, also known as ultra-resistant schizophrenia or super-refractory schizophrenia. In this, At least 8 weeks of treatment with clozapine with plasma level of greater than 350 milligram per liter and a failure to improve by at least 20% in total BPRs. Or persistent psychotic symptoms defined as 4 on at least 2 to 4 positive symptom cycles on the of the BPRS and current presence of at least moderate to severe illness on the BPRS, that is score of 45 and a score of 4 on the CGS. Then we can do clozapine augmentation. Despite the superior efficacy of clozapine, up to 30% of patients do not respond to clozapine, and thus we will augment clozapine with other antipsychotic. We can add haloperidol 2 to 3 milligram per day. We can add amisulpride 400 to 800 milligram per day. Aripiprazole 15 to 30 milligram per day. Lamotrigine 25 to 300 milligram per day. And omega-3 triglyceride 2 to 3 gram EPA daily. Risperidone 2 to 6 milligram per day. Sulpiride 400 milligram per day. And topiramate 50 to 300 milligram per day. This is the table for Marksway. Amisulpride 400 to 800 milligram per day. This has shown evidence and experience suggests that amisulpride augmentation may be worthwhile. Aripiprazole 15 to 30 milligram per day. Haloperidol 2 to 3 milligram per day. Lamotrigine 25 to 300 milligram per day. Risperidone 2 to 6 milligram per day. Sulpiride 400 milligram per day. Topiramate 50 to 300 milligram per day. Sodium valproate 400 to 800 milligram per day. And ziprasidone 80 to 160 milligram. And other treatments are somatic treatment. We can start with ECT in treatment-resistant schizophrenia. ECT, when added to antipsychotic, has shown a favorable response. Improvement is seen in maintenance ECT. Improvement is seen in self-injurious behavior, less hospitalization, and better functioning. But these symptoms are not sustained after the ECT is discontinued. Then RTMS in schizophrenia, auditory hallucination and negative symptoms. These are important targets for RTMS in schizophrenia, and low frequency RTMS over left temporoparietal cortex for medication resistant auditory hallucination. Then TDCS in schizophrenia. It is also given over left dorsolateral prefrontal cortex, and the targets we target on auditory hallucination and negative symptoms of schizophrenia. Then psychosocial management is social skills training, family-oriented therapies, assertive community treatment, and CBT. Others are personal therapy, DBT, vocational therapy, and cognitive treatment. Conclusion is when treatment fails, if the dose has been optimized, consider watchful waiting. Consider increasing the antipsychotic dose according to tolerability and pharma level. If this fails, consider switching to olanzapine or risperidone. If this fails, then use clozapine. If clozapine fails, then we can use the augmenting strategies, and others are non-pharmacological.
does not have any effective caregiver who can give her injections to there was slight improvement. People density can do that. Okay, like then that 6 of total duration. Changes the course of most of the patients you see here. So what is the time period for say response? कितना लगता है तो पेशेंट्स देख रहे हो so how much time does it take for the antipsychotic to have an according to you? I ask you. So how much time will you require in an average patient to see the response of an antipsychotic? 7 days में पता चल जाता है whether it is having an effect or not. कुछ तो दिख ही जाता है 2 weeks में पता चल जाता है माइल्ड इम्प्रूवमेंट नहीं मतलब जो है अगर रेमिशन नहीं होगा बट सम रिस्पॉन्स विल बी देयर तो ये जो क्लासिकली तभी जो सेकंड कौन सा केन के नेक्स्ट ना हो केस क्राइटेरिया फिर नेक्स्ट मॉडिफाइड इसमें फिर उन्होंने 4 to 6 कर दिया नेक्स्ट डीएसएम का ना जिसमें एक में 3 to 6 है और एक 6 weeks का है कौन सा है
So nice is 4 to 6
Nice.
weeks.
one
Mostly is 2 to 3.
one of them should be 2 to 3 weeks में you see more effect and one you rule out late response one at least you have to try. For 6 weeks you'll find very less patients मिल सकते हैं जिनमें हम अब जो है रात तो 3 हफ्ते में चेंज कर ही देंगे सिटी ऑफ हम लोग यहाँ पे एडवर्टाइज फॉलो अप यू विल सी व्हाट पेशेंट्स आर कमिंग देयर participants ठीक ही नहीं हो रहे this is schizophrenia something that you obtain criteria modified criteria etc क्या अस्पताल में and hospitals people should study and come okay. Next time onwards say something you can add one patient if you are seeing or have seen was there or relevant case because you after all this is theory and this is what you are doing is that is your bread and butter. You are going to apply this knowledge in your patient. So practical comments that if you have seen some patients, whether one patient who did not respond to one antipsychotic at all, but responded very well to another antipsychotic, that will also be okay. Some patients are responding very well when stop their haloperidol, then they relapse. We have to restart first generation now bettering many. Okay, some patients have a miraculous response to aripiprazole, minoxidil. Some patients they suddenly respond very well to the second generation. Okay, benzodiazepine, the side effect, clozapine, the side effects. Tolerability of clozapine is a big issue. Your tachycardia, constipation, patient pain. That is the problem. ठीक है सबसे ज्यादा तुम लोगों की उसमें कौन सा ड्रग सबसे वेल टॉलरेटेड अगर तुम देने जाओ तो तुम लोग ये सब देखा करो ना चेक करके सेकंड जनरेशन में कौन सा सेडेशन करने सेडेशन और Haliburton is important. Real pieces you got 6-9 minutes or instead of the electoral also ठीक है वैसे पाना and sulfide is very well done and sulfide से बहुत ही कम EPS भी कम मिलता है weight gain भी कम मिलता है और उससे हायर डोज पे जाओगे तो फीमेल में gain it has got 3 times more conductivity than steroid. I think I have not seen because we don't go for high dose and sulfide but it's a well done. Baki, I presume if you start a little bit slow, then it also is good. We'll talk about it, but Duracetone, cariprazine, so they have 1.5 milligrams to payload for severe akathisia, and Duracetone again. Ziprasidone was also very well tolerated. For some reason, it is for reasons that are not clinical, it is not. Ziprasidone was very well tolerated. Ziprasidone, acinapine also came and went, also well tolerated. Okay.